Okay, so let's start our discussion on the importance of optimal sleep in Parkinson's disease. So objectives, we're going to talk about insomnia and poor sleep in Parkinson's disease. We'll talk about snoring and sleep apnea, which is obviously a very big topic in sleep in general. We'll talk about restless leg syndrome and periodic limb movements during sleep, excessive daytime sleepiness in Parkinson's disease, and then we'll end with a very important sleep disorder that is often under-recognized and undiagnosed called REM sleep behavior disorder. So first off, we'll just kind of go into some introduction. So James Parkinson, who's the physician that Parkinson's disease is named after, in his essay on the shaking palsy, published in 1817, noted that many patients he studied were greatly affected by disturbed sleep, in addition to motor symptoms. Tremulous motion of the limbs occur during sleep and augment until they awaken the patient, and frequently with much agitation and alarm, he wrote in this essay. In his description of case 6, which was a patient of his, he wrote the patient's attendants observed movements during sleep that increased until it awakened him, when he was always in a state of agitation and alarm. So this possibly could be the first description of REM sleep behavior disorder, which is when an individual acts out their dreams. So sleep disturbances are very common in Parkinson's disease. It's estimated that approximately 60 to 90% of individuals with Parkinson's have sleep issues, and that can include both nighttime symptoms and even daytime symptoms. And development of sleep disorders in Parkinson's may be the result of the actual neurodegenerative process that actually triggers Parkinson's disease to develop. In 1988, a survey noted that 98% of individuals with Parkinson's had experienced disabilities at night or on waking since the onset of Parkinson's disease symptoms. So you can see that it's a very, very common issue with sleep. Now, what are the common sleep disturbances in individuals with Parkinson's? They actually are very similar to the general population, except for REM sleep behavior disorder. You can have insomnia, daytime manifestations of just daytime sleepiness and just being tired all the time, sudden sleep attacks, which is when an individual just without warning falls asleep. It's not passing out like a syncopal episode. It's just you're awake one moment and the next thing you know, a person's asleep. Sleep apnea, restless leg syndrome, periodic limb movement disorder, circadian rhythm disorders, which is when the internal clock that guides what time the brain wants to go to sleep and wake up, that can get altered. And then parasomnias, which can occur in non-REM sleep, which would be stage 3 sleep typically, which is like sleep talking, sleepwalking, or sleep terrors, or REM parasomnia, which is the dream enactment behavior, which we'll discuss at the end. Now, disrupted sleep can affect health, mood, and overall quality of life in individuals with Parkinson's disease. And I think that's kind of an obvious, whether you have Parkinson's or not, when a person is not getting a quality sleep or they don't feel well rested, it impacts pretty much every aspect of our lives. And when individuals with Parkinson's don't sleep, it also affects the caregiver's sleep. And in clinic, as a sleep specialist, and I'm sure Dr. Evidente in his clinic, as a Parkinson's disease specialist, hears this as well, but spouses often are exhausted and they're kind of, in terms of how they actually express that to us. But it can be exhausting, whether it's because of frequent, waking during the night to go to the toilet, because that's a very common symptom, or the dream enactment behavior or snoring. And it's exhausting because depending upon the level of Parkinson's disease, these individuals may also need, assistance during the daytime as well. So it's important that the spouse or bed partner get good quality sleep so they too can provide assistance and then also have a good mood as well. Any questions so far? Should we pause for questions?
Any questions so far to Dr. Patel? Yeah, I think we can proceed. I think
okay.
This is the first and most important topic, insomnia.
Perfect. So let's talk about insomnia. So insomnia is going to be the most frequent sleep disorder in individuals with Parkinson's disease. Now, insomnia is a general term, which can be either difficulty falling asleep, difficulty staying asleep, early morning awakening, or non-restorative sleep, meaning that a person sleeps, but they just feel fatigued when they wake in the morning. Now, terminal insomnia is an old terminology, but basically that's when an individual falls asleep just fine, but then they wake up at 2, 3 o'clock in the morning, and then they can't get back to sleep. But they typically don't want to wake up until, say, 5, 6, 7 o'clock in the morning. Now, what are risk factors for insomnia in individuals with Parkinson's disease? It could be the neurodegenerative process of Parkinson's itself. Female sex also increases the risk of insomnia in Parkinson's. The duration that the individual actually has had Parkinson's. Also, comorbid depression and even anxiety disorder can also increase the risk of developing insomnia. But then even medications themselves, dopamine agonists like carbidopa, levodopa, pramipexole, ropinirole, those are common medications used to treat Parkinson's. Those medications may contribute to insomnia, or even having to come off those medications and the withdrawal could also trigger insomnia as well.
Okay, couple of questions here. First is, if somebody has a enlarged bladder or some bladder issues and they wake up several times during the night, is that considered insomnia?
It is. Yeah, that would be considered what's called sleep maintenance insomnia, right? So insomnia can be secondary to multiple different things. It could be secondary to your bed partner snoring. It could be secondary to waking frequently to go to the toilet. Insomnia can be secondary to sleep apnea. It can be secondary to restless leg syndrome. So the way we as sleep specialists tackle insomnia, it's almost like pain, right? When you go into your doctor's office and you say, I've got pain, well, he or she's going to ask you, well, where's the pain? What triggered the pain? What worsens the pain? What improves the pain? So they have to characterize what kind of pain is it. And it's the same approach for us in sleep medicine when a person comes in reporting insomnia. We have to figure out what kind of insomnia is it? Is it a problem at the start of the night, in the middle of the night, at the end of the night? Is it triggered by a sleep disorder like restless leg syndrome, frequent nighttime urination, which can often occur in the setting of untreated sleep apnea? Or is it secondary to the bed partner spouse? Or is it secondary to restless leg syndrome? So we kind of have to figure out what is it? Or is it secondary to a psychological condition response, meaning that the brain has learned over time not to view the bed as a place to sleep, right? And that's kind of a diagnosis of exclusion, where if we've ruled out other organic sleep disorders that we can diagnose and specifically treat, if none of those are there, then we'll make a diagnosis of what we call psychophysiologic insomnia, where basically the brain has learned a new habit. And that's where we employ cognitive behavioral therapy for insomnia to try to retrain the brain to learn to sleep again.
So it's not just what is the ideal amount of hours of sleep that patients with Parkinson's should aim for?
It's the same, as individuals without Parkinson's disease. So there's, this myth, so to speak, that as we get older, that the number of hours of sleep declines, and that's actually false. So all adults should be averaging about 7 to 8 hours of sleep per night. There are characteristics of quality of sleep that do change as we age. So one is going to be, it is common to wake up more during the night physically as we age. And then there's other actual changes that occur with the quality of sleep. So the amount of time that we'll spend in stage 2 sleep, which is one of the 2 levels of light sleep, can increase. And then the amount of time that we actually spend in stage 3 sleep and REM sleep, which are considered the 2 levels of deep sleep, will decline slightly. It's not a dramatic change, but there is slight change, which is statistically significant. But in terms of the quantity, that remains the same.
Ooh, which means what, 8 or 9 hours?
7 to 8.
7 to 8 hours. Got it.
Yeah.
Now, if a patient though feels very rested with 6 or 7 hours of sleep, and they say, I've been doing this all my life, and then they come to my office, they're having some cognitive issues and sleepiness during the day. I mean, should we aim for more if they've been doing this all their lives?
I mean, that's a great question. And the short answer would be, it would be worth trying. I mean, I've had patients over the years where, these are young individuals, even without Parkinson's, that, they had sleep apnea, treating it very well. They were sleeping, 7.5 hours per night, very good quality sleep, but yet they were still tired during the daytime. And we, reevaluated, ruled out other issues, no medications, nothing else that we could identify that was actually causing them to still feel tired, though they were getting perfect quality sleep and the sleep apnea was very well controlled. So what I would end up having them do is just progressively every week, try to add on an extra half an hour of sleep to see if your brain is programmed to require more than what we say is the average, right? And I've had cases where I have this was, almost 10 years ago, but he was 40 at the time. It wasn't until he got to 9 hours of sleep per night that he actually felt rested. And it's not common, but it can happen. Like my wife, she claims that she needs 8.5 hours of sleep per night. I think she just likes, not getting up in the morning, but don't tell her I said that.
Yes, well, questions from the audience.
For any person that, as we have developed as a species, we have had a tendency to get up in the middle of the night, say, before central heating, put fire, where you would be up and 10 or 15 minutes to go back to sleep. And cultural, where up in the siesta, so small, then catch up next culture with some developmental situation where we are open part of our genetic makeup.
Yes and no. Yes, in the sense that there are behavioral, there's conditioned responses that have occurred over time, many of which you've described there. But take me, for instance, right? I sleep straight through the night without any assistance at all. I don't take any medications. So the short answer would be like Matthew Walker in his book. I'm sure most of you have heard of Matthew Walker. In his book, he writes that it's not normal to sleep straight through the night. And I have, for years, have countered that it actually is normal to sleep through the night. And I'm a living example of it. And I don't take any medications. I do have sleep apnea and I do wear a CPAP, but even with that, I sleep straight through the night. The only reason why I wake up would be because of an external factor, whether my wife gets up or our 6-year-old son comes into the room and wakes us up. So the short answer would be is it could be all of the above, right? There are environmental factors that could play a role. There could be genetic factors. I mean, there's so many individual factors, but as a general rule of thumb, we're kind of averaging across, all populations.
So a spin-off to that question, what is better, 8 hours of continuous sleep versus 2 hours, I wake up, then another 2 hours, then I wake up, another 2 hours, then I wake up, and then 2 hours, I wake up, it's still 8 hours, right?
Yeah.
So which is better for the brain and for the body? 8 hours of continuous sleep or 2 hours, chunks of 2 hours each times 4?
Continuous would be much better, right? Because when you have disrupted sleep, it also affects how the brain's able to progress through the different sleep cycles, and various different functions happen in the body depending upon the actual time of the night, right? Not during sleep itself. It's everything, every cell in the body has an internal clock. So at 11 p.m., certain cells will do a certain function. At midnight, certain cells will do a function. So, and it also is tied to the level of sleep that you're in, meaning whether you're in stage 1, stage 2, stage 3, or REM. So if your sleep is broken, that can impact, like for instance, if your liver was meant to do some kind of regenerative function at midnight during stage 2 sleep, but yet you're laying awake for half an hour at midnight, well, your liver is not going to be able to do that regenerative function for that night. It's not that it will do it as soon as you go back to sleep. So it's not tied to actually sleep itself. It's tied to the actual clock and sleep. So.
Yes, go ahead.
What are the long-term effects of taking a sleeping pill for a healthy adult?
We're going to talk about that next.
Okay. All right.
Yeah.
Hold on.
The female sex. Again, looking. When I get this, I want to sing. I don't know. Looking over time, before there was artificial breast milk or whatever, and when families were large, women would frequently be getting up to feed their newborns every 2 or 3 hours during the night, and then before, just when they were getting out of that, they had another one coming along. And as you've witnessed, your 6-year-old comes in to wake up your wife to see what's going on. Is the gender, is it caused by these kinds of things, or is there something about the gender itself that makes women more prone to insomnia?
Could be all of the above. Truthfully, I mean, it's not, I can't give you like a specific that yes, it's because women are the ones that have to wake up in the middle of the night with a newborn child, right? Not every woman has had children, right? Not every woman has to breastfeed. So from that standpoint, we can't say that it's one specific thing, right? We know if you look at in mental health, right, we know that the female sex has a higher tendency to have anxiety, depression. So, and that could be for various different reasons. There's genetic factors for having mood disorders as well, right? And we know that depression and anxiety can also cause insomnia as well. So it's multifactorial in terms of there's multitude of things and reasons why the female sex could have a higher incidence of insomnia. So,
I'd like to add though that estrogen does affect Parkinson's. So for instance, where is Parkinson's more common? Is it more common among men or women? It's men, right? Which tells us that estrogen must be protective against Parkinson's, right? So it must have some effect on sleep as well.
it does, and I'm glad that you brought that up. So sleep apnea in women, right? So this is something that's not very well known in that when a woman is premenopausal, her risk of having sleep apnea compared to the man of the same age is 50% less. So she's half as likely to have sleep apnea compared to a man of the same age premenopausal. Once that woman crosses through menopause, just by virtue of completing menopause, now her risk of having sleep apnea compared to the man at the same age is 100% the same. And this is controlled for physical attributes. So it's got nothing to do with the physical attributes, right? You could have a thin woman that's not overweight, but now that she's finished menopause, now her risk of sleep apnea doubled because of menopause. And the reason for it is that estrogen premenopausal and progesterone are both protective against developing sleep apnea. Progesterone is a respiratory stimulant. It promotes women to breathe deeper. And estrogen, premenopausal, is kind of involved in fat cell distribution, right? Potentially for helping with childbearing. But as a woman goes through estrogen and then, as the woman goes through menopause and the ovaries start to power down, you're not producing as much estrogen. So now fat cell distribution can change to where you can start getting increased fat cell distribution within the muscle layers of the throat itself and even the tongue. So that can cause the throat itself, not the neck. So don't worry, women, not the neck, but the throat itself can get narrower, which in turn can increase the risk of sleep apnea. And that happened to my own mother even. But it's a very common thing. So we have a lot of postmenopausal women that are very thin that you would think, gosh, no way that you have sleep apnea, but yet they come in with symptoms of insomnia. And when we test them, it turns out to be really severe sleep apnea.
The one last thing I wanted to add to that last bullet of yours is that some medicines for Parkinson's can cause insomnia. The most notorious of which is amantadine. I'm not sure whether any of you take amantadine in the audience. We use it for tremors, we use it for dyskinesias, and it causes insomnia. So I usually tell patients not to take it after 5 p.m. And the flip side is some medicines for Parkinson's are sedating, like the dopamine agonist. And sometimes levodopa itself is sedating. And so for patients of mine that get sedated with these medicines, I usually give them at night. It actually helps their sleep. Okay, so, and then at the flip side, if you withdraw these medicines, which is what Dr. Patel's slide is saying there, the last bullet, if you withdraw these medicines for whatever reasons, whether blood pressure drops or they develop hallucinations or confusion, they're now more demented, these medications are not that safe anymore. Sometimes the sleep becomes disturbed because these were sedating and helping their sleep to start with, and therefore withdrawing these drugs will cause insomnia. Okay, let's proceed with your next slide.
So like I mentioned, I mean, in terms of the way we evaluate insomnia, it's going to be determining what kind of insomnia is it, and then ruling out other sleep disorders. From a treatment standpoint, if the insomnia truly is a psychological issue, not that it's made up in your mind, not like that, but in the sense that the brain has learned a new habit, right? So I don't know how many of you have had or have issues falling asleep, but one of the biggest mistakes that people make when they're trying to fall asleep is that they're tired. It takes an hour for them to fall asleep, but they're tired, so they go ahead and get into bed at the same time, no matter what, hoping that they'll collectively get more sleep. But what happens is they're laying in bed, they're thinking about various different things, or those that just have a racing mind, and the mind just lays there racing. But what you're doing is that you're just telling your brain subconsciously that, hey, it's okay for us to lay awake in bed and just think about anything and everything that you really don't need to think about at that point in time. But you're self-perpetuating the issue, right? So think about, for all of you that have children, when we were training our children as babies and toddlers to sleep, right, we give them cues. We give their brains cues to kind of learn this. All these different things are signs that it's time to sleep. So we're actually conditioning the infant and the baby how to sleep. And as adults, our brains are still as amenable to change. So we can recondition our brains to view the bed as a place to lay awake rather than a place to sleep. So that's where cognitive behavioral therapy for insomnia can come in. And same thing can occur in the middle of the night. You know, I have many patients that will tell me that I fall asleep just fine. I sleep and then I wake up at 3 a.m. and my mind just takes off, right? And they just lay there for an hour with their mind racing. That's the worst thing you can do, is because you're promoting your brain to want to be active, and you're telling your brain that it's okay for us to lay here for an hour at 3 a.m. and just think, right? So that's the kind of psychological insomnia I'm referring to, is that the brain has become conditioned to not want to go back to sleep or not go to sleep. So there's cognitive behavioral therapy for insomnia to address that. There's sleep psychologists. In fact, we have sleep psychologists in our sleep practice that are trained to address this. Medications are not going to be the solution. They're a Band-Aid, right? They're not going to actually get to the root issue. Long-acting levodopa carbidopa can improve sleep-associated motor symptoms that can also improve sleep quality. Dr. Evidente kind of alluded to that. Medications to address that question. So it depends on the medication, but our general rule of thumb now with, sleep medications, whether it's Ambien or temazepam, Valium, all of those, is Lunesta, they're all short-term. They should all be used for short-term. Ambien was only FDA approved for about 30 days of use for acute insomnia. None of these medications actually are FDA approved for long-term usage. And there's a lot of data that's come out. And even in 2013, there was a big paper that was published in the British Medical Journal showing that individuals that have taken these medications for at least 3 to 4 years or longer, that there's an increased risk of all-cause mortality, meaning death from any cause, by about 4 times, right? So that was kind of a big eye-opener for us in sleep medicine, saying, all right, there's an issue here. Fast forward, now there's more research over the last several years showing how deep sleep, stage 3, is very important for brain health. There's a system in the brain called the glymphatic system, which is almost kind of like the lymphatic system in the rest of the body. So it's kind of like a sewer system, so to speak, for the brain, which starts to operate during stage 3 sleep. So think about it like a dishwasher, right? So during stage 3 sleep, which is a deep level of sleep, which generally occurs in the first third of the night, once our brain enters into that, the brain turns on the dishwashing system and it cleans out toxins from functioning all day long. Now, these medications can impair that system from actually operating. So it can force those toxins to build up. And these toxins, some of them can actually contribute to cognitive issues, dementia, potentially even Alzheimer's disease. So that's why, as a rule of thumb, we're trying to help individuals get off of these medications, to answer your question, whether you have Parkinson's or not. This is the rule of thumb for any individual, regardless of what age. So that's been our focus, because too many individuals over the years have just been put on these medications without actually trying to identify what's the root cause of this person's sleep issue, right? Which is the way we in sleep medicine address it, is what's the root cause? We're not going to give you a medication. That's a Band-Aid solution, right?
So which begs the question, if this is primary insomnia, it's not due to something, right? It's because of age and their Parkinson's. What medicines, therefore, can we prescribe long-term to these patients without increasing their chances of falling and increased mortality? What is safe to prescribe?
I mean, technically, there really are none.
Really?
Yeah.
Wow.
Yeah, because most of these medications, even if it's like trazodones, for instance, right? They all have sedating effects. They can cause drowsiness. So they all can increase the risk of individuals potentially falling. And you have a patient with Parkinson's disease that may have issues with gait. You give them a sedating medication in the middle of the night, and then that in turn could increase the risk of falls.
Well, I guess you have to strike a balance between lack of sleep and the consequences of prescribing a drug, right? Both are not good. I guess which is the less of two evils? Prescribing them a medicine that perhaps can increase their chances of falling in the middle of the night, but at the same time, can give them that restorative 8 hours of sleep, and therefore the following day they feel like $1 million. They're rested, they can think better, they're clear-minded, their Parkinson's is better. Versus, okay, oh no, I'm one of those doctors that I'm afraid that I'm going to make you fall in the middle of the night. I'm not going to prescribe you anything.
No, and it's a great question, because we have to kind of judge it case by case, right? I mean, Dr. Evidente is completely correct in the sense that you have to judge what's the lesser of the two evils, right? Having a potential fall or being sleep deprived and increasing your symptoms of Parkinson's, which could
And
really,
dementia.
and really greatly affect your quality of life. But truth be told, that there is no perfect medication. We kind of have to judge it based on.
Okay, so given there's no perfect medicine, so in my mind, the worst of the worst would be the benzodiazepines.
Of course,
yes,
yeah,
right. So
yeah.
that means Klonopin, the temazepam, what else? The Xanax, the Valiums, right?
Mhm.
Which are old style therapies. Are back in the day, that's what everybody receives, right? A benzodiazepine. So okay, let's scratch that out. Okay, so what about the next safer set of drugs outside of the benzos?
Yeah, I mean, we consider trazodone.
Okay, which is an antidepressant.
Yep. We consider gabapentin.
Gabapentin, which is a seizure drug.
Yep.
What about mirtazapine?
I was going to say that next. Yeah, we could use mirtazapine as long as you're mindful of potential increased appetite, weight gain.
Okay, what are your thoughts about quetiapine? Because I love quetiapine for my patients with Parkinson's.
At low dose, I mean, it can work well. But of course, we want to make sure that we don't develop any side effects at higher dosages. But yeah, I mean, those could be considered. So.
Okay, questions?
I was diagnosed with RBD. I got some helpful hints like put a mattress on the floor next to your bed. I think do that. The other recommendation I did take up, which was melatonin. What is your?
We're going to talk about the supplements.
Fairly benign, but now recently, maybe in the last 6 months, I've heard some things about maybe melatonin has some adverse effects or whatever. What is your feeling?
Okay, let's segue to the supplements.
Yeah, sure. So melatonin, that's a great question. There's a lot of debate in the sleep medicine world right now about melatonin. Should individuals, take melatonin long term? In RBD, melatonin actually is a recommended treatment, right? So from that standpoint, melatonin is very important. Yeah, it does, and there's a physiologic reason why it actually helps in RBD. There's several concerns with long-term usage of melatonin, though, because melatonin technically is a hormone. There's concerns that it could result in our brains not producing as much of its own melatonin, right? The pineal gland in the brain produces melatonin. So there's concerns that it could result in tricking the brain to think that, hey, there's already plenty of melatonin, so we don't need to produce our own, right? And that's a problem because our own internal melatonin has significantly more functions for the body than synthetic melatonin can actually provide.
Although, isn't it true that as one gets older, especially if you have Parkinson's, we're really not producing enough melatonin, are we?
No, because you could get calcification in the pineal gland, right? So that could potentially.
Right.
Yeah.
So we measure the melatonin levels in the aged population, and more so with Parkinson's, their melatonin levels are lower. Isn't that true?
Yeah,
in which case, if you give them a little bit of melatonin it's like dopamine, I guess. If they're not, Parkinson's is all about lack of dopamine. So give them dopamine, you fill the cup. So in the same vein, if we give a little bit of melatonin that somebody is not producing enough of it, isn't that a good thing?
It is. It's a good thing. But the other major concern, though, is that production of melatonin is not regulated, right? So over the course of the last 3 to 4 years, there's been a higher incidence of childhood overdose with melatonin. And the reason being is that there's no FDA regulation on the production of melatonin. And what's been discovered is that a bottle may read 5 milligrams of melatonin, but when it's tested independently in a lab, it may actually contain 10 milligrams of active melatonin. So that's what's happened in young children, and not overdose to a point of causing death, but to the point where obviously they're unconscious.
So, but are there published reports of deaths from melatonin though?
No, there's not.
Right.
Not that I'm aware
you
of.
can't kill somebody with melatonin, right?
Yeah.
Okay, good.
Hopefully not.
So if you're or you're gonna kill yourself with melatonin, right?
Hopefully
but you can
not,
with a Valium or a benzodiazepine. Yes.
Yeah. There's a question back there.
And then is there one more question before I forget? Is there a concern between melatonin and the combination of melatonin and alcohol at night? The same way that we're not supposed to combine alcohol and a benzodiazepine.
Not particularly, except for melatonin can trigger nightmares, and even alcohol can trigger bad dreams and potential nightmares. So there could be a synergistic effect there. So.
And then there's the ER, which is the extended release, and the IR. So which one is better in terms of sleep maintenance?
The extended release. I typically recommend. I mean, the melatonin that I recommend for most of my patients, whether it's in the setting of REM sleep behavior disorder, age, or just sleep, is going to be, there's one specific called REM Fresh, which you can get on Amazon, but it's an extended release where it's a slower release preparation. So it also provides, potential coverage in the second half of the night as well.
So if it's a sleep onset insomnia, I guess the immediate release will work. If it's a maintenance issue, sleep maintenance issue, interruption several times during the night, I guess the extended release will make more sense.
Yeah, anecdotally though, I've noted that individuals that take the extended release melatonin are less likely to report the side effects of nightmares.
Because you don't have the peaks and
Exactly.
valleys like
Yeah,
this. Got
yeah.
it.
So it's very infrequent that I would recommend short-acting melatonin. And that's my own personal
And then
preference.
last question before I turn it over to the audience. What is the maximum dose of melatonin that you would recommend before you say, oh, the risk-benefit ratio is not favorable for more benefits beyond this dose?
10 milligrams.
So 10 milligrams is your limit. Okay.
Yeah.
I do 15, but I heard some do higher, and I kind of question whether that's safe
Yeah.
to do higher than that. Although I've heard from our academy meeting sessions in the past that there are cardiovascular side effects with whopping doses. There was one patient of mine that came to my office. You take melatonin. I says, yeah, how much melatonin do you take? I was busy taking mine. I said, I take 50 units, 50. Did you just say 1.5 or 50? Is that 50? I said 50 units or milligrams. I said 50 milligrams of melatonin, which is whopping.
But here's an interesting tidbit. So there's actually a lot of research being done in using very high dose melatonin, and I'm talking about in hundreds of milligrams in oncology. So there's a physician, I can't remember name, but diagnosed with an aggressive skin cancer, and one of the treatments was adding like 200 to 300 milligrams of melatonin. So there's also research showing that melatonin can actually have an anti-cancer effect in the body as well. It doesn't mean that you all go out and start giving yourself hundreds of milligrams of melatonin to prevent yourself from getting cancer, but there is ongoing research. So that's an interesting thing that we're learning. What's that? In this one specific case, yeah.
And FYI, it's also used for headache syndromes.
Mm-hmm.
It works for headaches. Some migraine syndromes, they respond to melatonin. The last thing I want to add is that it's actually a very, very powerful antioxidant.
It is.
So it's not a bad supplement. It is something that the brain produces, and I think there's less of production if you have Parkinson's. It's a good supplement to a certain degree. Okay.
Yes, sir.
Was there a question in the back? Yeah, there. Yeah, go ahead, please.
What's been your experience with the supplement of exercise, either aerobic or resistant, and insomnia?
Well, I follow up to that. What time should we exercise?
Yeah, sure.
Such that the sleep will not be affected.
Well, exercise is great for everything, right? Regular exercise activity definitely is very helpful for sleep in general, whether you have insomnia or not. One thing, however, there's a caveat to exercise is that you want to avoid strenuous exercise within 2 to 4 hours of bedtime. The reason being is that there's a physiologic process that happens that as the evening approaches, our core body temperature starts to decline. And that's necessary for the brain to start to release its own melatonin. So if you exercise heavily, spend an hour in your hot tub, right before you go to sleep, that raises your core body temperature, which in turn may delay the onset of melatonin. So what our intrinsic melatonin does in the brain is that typically, like my bedtime is 9 p.m. I usually am asleep by 9. So around 7 p.m. is when my brain starts to release its natural melatonin, which in turn then slowly starts activating the regions of the brain that actually activate sleep. Because there's several neurotransmitters that are actually involved in sleep. If the core body temperature is too high, then melatonin won't get released, which in turn delays when you'll go to sleep. So that's why we always advise exercise is great. Try to do it more so during the day, especially with the sunlight. And that can also help with sleep at night.
So what other things will reduce the physiologic release of melatonin at night aside from exercise?
Exercise, yeah, of course.
What else can you think of? Will alcohol affect melatonin release?
Alcohol won't affect melatonin release, but light exposure will, right? So
What about, this is a touchy subject, what about sex before sleeping? Because I've been asked about this.
no.
It is a very touchy subject.
No, I mean, so as far as I'm aware, I'm not aware of sex before sleep affecting melatonin release. And, For most individuals, sex usually helps to relax the person to be able to get to sleep faster.
And what about bright light or darkness of the room? Would that affect the release of melatonin?
Of course. So blue light, right? So all of our color screens, TVs emit blue wavelength light. That's the reason why we're all day people, because of the sun outside emitting blue wavelength light. All of the LED screens that we all are constantly looking at all day long, those emit blue wavelength light as well, which in turn tricks the brain to think that the sun is out, right? Which in turn inhibits the release of melatonin.
So I do a lot of Facebook and emails and gaming before I go to bed in my big, large screen computer, screen. Would that affect my sleep?
100% it will.
Got it.
Yeah.
Okay. Yeah, go ahead.
There's one back there.
I think I know the answer to this, but can you make up for lost sleep?
And
should
a follow to that is it would night sleep. I mean, splitting the sleep between 4 hours at night and 4 hours during the day because they make up, like what he said. Is that the same as 8 hours at night? And then your second question was?
Should you take it when you can get it?
Meaning make up. Okay.
So the short answer is no, you'll never make up 100% of sleep lost. Right?
So if you've haven't slept in 2 days,
and then you crash for 24 hours.
and then it's 12 o'clock noon, and you're feeling tired, should you go lay down or should you wait till nighttime?
So you can lay down and take a nap, right? But what can happen is if you end up going to bed at 12 o'clock, over time, you may shift your internal clock to not want to go to sleep at night and actually sleep during the daytime, right? That's a circadian rhythm disorder. But to answer your first question is no, you'll never make up 100% of the sleep lost, and there's no way to do that. So we'll always live in a sleep deficit. The brain's in a constant state of wanting to try to make up for lost sleep, but it never will. And to answer Dr. Evidente's question about, well, it's a phenomenon called biphasic sleep, where individuals, will sleep 4 hours at night and they'll sleep 4 hours during the day. And there's a lot of debate about that. But again, it goes back to what we call sleep stage progression, where when you go to sleep, right, the brain goes through various different stages of sleep. And as the second half of the night approaches, you start spending more time in REM sleep, which is where we dream, less time in stage 3 sleep. And again, physiologically, there's various different functions that happen in the body associated with the stage of sleep. So theoretically, if you're only getting 4 hours here and then 4 hours later, you may not actually get the appropriate quantity of time spent in those deeper levels of sleep. So that may in turn actually impact how the body is able to function.
Now, if I'm a nighttime worker, and this applies to us, right? Like if we're on call for, let's say, a month, hospital call. So for those that work at night and then we sleep during the day, so is that a good thing or a bad thing or an okay thing?
I mean, it's a necessary thing.
I know it's necessary, but is it good?
But physiologically, no, it's not a good thing. Because there was a study looking, I think it was the Swedish or Danish army in the 1920s. They actually found that there was an increased risk of breast cancer in females that were working the nights, right? And there's been more studies over time as well. And that has kind of opened up the window over the years of looking at shift working, right? So whether it's medical employees or medical staff or other individuals that have to work at night. Again, it goes back to the circadian rhythm, right? The internal clock in our brains that determines when the brain goes to sleep and wakes up. When we don't sleep, when the brain is programmed for us to sleep, then you end up losing out on all those regenerative functions that should happen. It does not carry over to the daytime. So if a person says, well, I'm having to work, 3 nights a week from 7 to 7, so I'll sleep from, 9 to 3, and I'm still getting, 6 hours of sleep. Well, won't that make up for the fact that I'm not sleeping at night? And the short answer is no, it won't. Because again, remember, like I said earlier, each cell in the body, including the red blood cell, which does not have DNA, it actually has an internal clock. So it knows what time of the day it is. So based upon the clock, it knows whether it should be in a regenerative state, or if it should be in a daytime functioning state. So when a person is sleeping from 9 a.m. to 3 p.m., the cells in their body, like, hey, this is time for us to be awake. So they're not doing that regenerative function that should be happening at night.
So before we move on, what other supplements would you recommend? What about CBD and THC gummies?
So That's a great question and a very common question we get. So the short answer is with CBD, there's not enough research, showing that it definitely can help. There's a lot of anecdotal evidence, even with marijuana and THC. I would think once THC was legalized for recreational use here in Arizona, we saw a significant increase in individuals coming in saying, I'm taking gummies or I'm using a vape pen. Yes, I mean, we all know anecdotally that it can cause drowsiness, but with THC, right now, we're not recommending it as a sleep aid because too much THC can interfere with brain health, right? It can interfere with that washing machine mechanism that I spoke about earlier. So it's not good. Maybe if once it becomes potentially federally legal and there's opportunity to do more research, if it gets federally funded, then maybe then in the next 5 to 10 years we can give a better answer. But right now we're saying stay away from it.
Okay, what about valerian root?
Sure. I mean, there's so many different natural supplements out there, and none of them have been shown in studies to definitively provide consistent benefit. Some individuals will find benefit with it, others won't. So if a patient asks us in clinic, can I try these natural supplements? And well, our response will be sure. I mean, give them a try. We can't tell you for certain that they are going to provide benefit, but they may.
Oh, what about magnesium?
Yeah, same thing. I mean, magnesium is I had a discussion this morning actually with someone about magnesium, but that's a big hot topic right now about magnesium spray for sleep, for restless leg syndrome. And it certainly can help as well. Even progesterone is a common one for women. It's not a supplement, but progesterone is often prescribed because it has a side effect of drowsiness.
Well, what are your thoughts about hydroxyzine for sleep?
Yeah, hydroxyzine.
Antihistamine or Benadryl?
Yeah. So with Benadryl specifically, we are recommending against it because of its anticholinergic effects, which in turn can also impact the brain health as well. So we are recommending against Benadryl specifically. With hydroxyzine, I haven't seen any definitive research indicating that it has similar effects, but it has anticholinergic effects as well. So
it sure does.
Yeah, one can assume that it probably does have similar long-term effects, but it's commonly used by psychiatry, especially.
Agree, because it also has a good anti-anxiety effect.
Exactly. Yeah.
Yes.
What about music? One recently published by Daniel Levitin, a neuroscientist and a musician, called I Heard There Is a Secret Chord That David Played. It's a reference to Cohen's Hallelujah. But the subtitle to the book is Music as Medicine. And he makes the point that music has had a profound effect on the structure of the brain and how music generally, unless you're playing in a rock band, it won't hurt anything. Maybe you're hearing it if you're too close. But I'm just wondering, we use lullabies as a traditional method of helping babies get to sleep. Music, if you ask anybody, they'll usually find a certain phase of music that's very relaxing, very meditative. We know it affects the brainwaves. What is your feeling? And as far as I know, probably doesn't, like I said, have any downside. You mentioned you were surprised that there was no medicine, no pill to take for this insomnia thing. What about something like music?
Yeah, I mean, that's a great question. Music definitely can help, but it depends upon the kind of music, right? Classical music can be very soothing. There's actually a composer from the UK by the name of Max Richter who actually composed an 8-hour score working with neuroscientists at Oxford using tones and notes that generated tones that actually help to relax the brain and induce sleep. And it was interesting. I think the first show was in Berlin, and it was an overnight show where they actually had beds for individuals.
So everybody was allowed to sleep.
Yeah. So, I mean, I've used classical music to soothe myself to be able to go to sleep. So there is utility in it, but then at the same time, it also depends on how loud is it, things like that. But
what about the music, background music in your clock that plays like rippling water and a waterfall, or I don't know, seashells?
Yep. And it can be calming for the mind. So
okay, let's move on.
So tips for improving sleep. So the simplest way to start sleeping better with Parkinson's is just by adopting healthy sleep habits. Sleep hygiene, which I'm sure many of you have heard of. Sleep hygiene tips for patients with Parkinson's sufferers include sticking to a regular bedtime, following a consistent bedtime routine with soothing activities such as listening to music or reading a calming book, getting regular exercise, preferably early in the day, getting adequate exposure to light, whether outdoors or through light therapy, and avoiding long naps and naps late in the day. And the reason for that is when you nap too long or late in the day, it ends up pulling away from the pressure that we all build up for sleep as the day approaches. So as a rule of thumb, all sleep specialists will tell you, if you want to take a nap during the day, totally fine, but limit the nap to no longer than 30 minutes and before 3 p.m. And the reason being is that if you take a nap longer than 3 p.m. and or after, if you take a nap longer than 30 minutes and or after 3 p.m., you end up taking away some of that pressure we build up for sleep as the afternoon and evening approaches. So I'm sure you've all at some point experienced you took a nap for 2 hours and that night you just were a little bit more awake than usual and it was harder for you to fall asleep. And that's the reason why, is that you ended up taking away some of that sleep that you were supposed to get at night. You ended up giving it to yourself during the daytime when you took a nap.
What about sleeping too early? I've heard all too often, like in facilities for elderly or memory care centers, because of staff issues, they just put everyone to sleep at 6 p.m.
And that's ridiculous.
I know, but it does
Yeah.
happen. This is reality.
Yeah.
So
it
what do
is.
you think about, putting everybody to sleep by 6 p.m.?
Yeah, I think that's silly. I mean, it's not a
Night out.
It promotes insomnia, right? So if you have an individual that
Well, they're all awake by 2 a.m. That's the issue.
or the individuals whose brain is programmed for him or her not to go to sleep until 10, they're going to be laying awake for 4 hours in bed, and that's just going to trigger insomnia develop and keep perpetuating it. So
What's the earliest that you would think is physiologic for us to go to bed? What's the earliest time?
well, it varies, right? Because as we age, there is a circadian rhythm disorder called advanced sleep phase disorder, which can develop, right?
Right.
So advanced sleep phase disorder basically is when your internal clock gradually shifts your internal bedtime to be earlier and earlier. And I've had patients in clinic where they naturally go to bed at 7 p.m. and then they wake up at 3 a.m. Now they've got their 8 hours of sleep, right? So and at 3 a.m. they're awake, but they've got 8 hours. They feel great, right? What are they going to do? I mean, I guess they could go for a walk as long as it's safe outside, but that can actually happen. And it's a sleep disorder called advanced sleep phase disorder. And as we age, individuals are at higher risk for it. And there's a multitude of factors, right? Big one could be environmental, meaning that now, older adults, retired, not spending much time outdoors, and it's just easier to go to sleep earlier because you've been, he or she's been spending the time, doing various different things around the house. But ideally, I mean, it should be, I would say probably close to around maybe 9, 10 p.m. typically would be average.
And is that influenced by the season? Like, for instance, what if sundown is, let's say, 9 p.m., like summer? So should I sleep later during summer and earlier during winter?
No. So there's a phenomenon called social jet lag, where again, it all goes back to what I said earlier about each cell in the body having its own internal clock and knowing what time of the night it is, right? So there's a phenomenon called social jet lag that was first discussed actually at University of Arizona, Tucson, where individuals, and what social jet lag is basically, say on the weekdays, I go to bed at 9 p.m. My alarm goes up at 4. That's my 7-hour window. But then on Friday or Saturday, I don't have to go to work. I'm like, I'll stay up a couple of hours to watch a movie with my wife or go out and socialize. Well, that 2-hour difference in terms of staying up 2 hours later than my usual, that phenomenon is called social jet lag. And what ends up happening is that it ends up increasing the risk of obesity, depression, diabetes by about 30% to 40%. Again, it goes back to when on Friday and Saturday, if I don't go to bed at 9 and I go to bed at 11, what my body was supposed to do from a repair standpoint from 9 p.m. to 11 p.m., now it's gone. And it can't do it later on. So that cumulative effect can result in long-term health consequences. So no, you should consistently go to bed at the same time every night, regardless of whether it's a summer, it's a spring, it's a winter. But in reality is that it's not always possible either, right? So we have to do the best we can. But if at all possible, we promote trying to stick with the same bedtime routine and the same bedtime and wake time as consistently as possible.
All right, let's proceed to your next slide.
So creating a cool, dark, and comfortable sleeping environment, restricting bedtime activities to sex and sleep only. Again, that's more from a psychological standpoint to promote the brain to view the bed as a place to sleep. Turning off screens an hour before bedtime, reducing liquid intake before bedtime to avoid waking up to go to the toilet, avoiding caffeine, alcohol, and even tobacco, and then eating a healthy diet and avoiding large meals at night. But even a meal heavy in carbohydrates and sugars. So there's studies that have been shown that having a heavy carbohydrate meal and meals with sugar prior to bedtime actually can impact the quality of sleep. So having a diet heavy in carbohydrates and sugar can actually increase the amount of time the brain spends in stage 2 sleep, which is one of the 2 levels of light sleep, which in turn decreases the amount of time that we spend in deep sleep. So having to, and I've kind of observed that I avoid sugar and carbs pretty regularly, but the times where I may splurge and have dessert, at a dinner meeting or something, I can definitely tell the next morning I don't feel as rested. I would have slept the same quantity and slept well, subjectively, but I can definitely tell I don't feel as well rested. So
Now, many of my patients take some alcohol at night, so and they say it makes them sleepy.
yeah.
But you're saying avoid alcohol. So what does alcohol do to your sleep architecture?
So alcohol, of course, can make you drowsy, right? But
Right.
when the body metabolizes alcohol, which typically is about 2 hours after our last drop of alcohol, the brain will start waking up excessively. Not you physically, but the brain can start waking up in the background for 2 to 3 seconds at a time. Anything that triggers a brain to wake up for a few seconds at a time can actually shift the brain to spend more time in light sleep, which is stage 1 and 2. And it impacts the brain's ability to get into the deep sleep, stage 3 and REM. So you may sleep 8 hours, having had a couple of whiskeys before going to bed, but you're not going to get as good quality sleep.
Ergo, how many hours before sleep, bedtime, can they safely take, their glass of wine?
So we recommend avoidance of alcohol within 2 hours of bedtime.
Okay.
Yeah.
Okay, questions?
Night is a very broad term. Can you be a little more specific? Clock times?
In terms of,
Last meal.
oh yeah, avoid it within about 2 to 3 hours before bedtime.
3 hours before bed. Okay.
Yeah.
So I have some clients who eat at 8 o'clock at night, and that drives me crazy.
Yeah, drives me crazy too. Yeah, it's too late. What's that? What time do they go? But what time do they go to bed?
I lived in Spain for a year when I was a student, and our dinner time was 10 p.m. And I was tortured.
Yeah.
I was really tortured because I lived with a bunch of students, and there was a senora that comes to us every evening and brings us dinner, and it was part of the rent, so to speak. And it was simple torture to eat at 10 p.m. and then go to bed after that, right? Because you got to go back to work at 8 a.m. the following day. Yeah, I don't know how they do it, but they have siesta time. Yeah, but that's old Spain though. My last trip to Spain, there was no more siesta time. Back in the day when I was a student, everything was closed. The only thing open was the ER and the police. Banks are closed. The outpatient clinics are closed. Nobody picks up the phone. Shops are closed. Shopping malls are closed. Nothing. Everything closes from 2 to 4 p.m. That's their siesta time. It is sacred. And so it was. So I think that changed when they became part of the EU, because now economy it was bad for the economy. They have the siesta time with everything shutting down, the entire country shutting down for 2 hours during the day, right? When you could have earned oodles and oodles of euros during that time. Yeah. Okay, go ahead.
So let's now step into obstructive sleep apnea. So obviously, obstructive sleep apnea is when an individual has collapse of the tongue, the soft palate, and the back of the throat, commonly associated with snoring. The prevalence is estimated to be as high as 60%. There's no apparent causal relationship between Parkinson's and obstructive sleep apnea. But sleep apnea, because the brain keeps detecting repetitively that a person is not taking a normal breath, the only way the brain can correct our breathing when we're sleeping is that it has to wake up. So that results in broken sleep or sleep fragmentation. And then the repetitive drops in oxygen can also contribute and even worsen Parkinson's disease and symptoms. Treatment, obviously the gold standard still to date, since for over 40 years, is going to be CPAP, which is the mask, which I'm sure most of you have heard of. Many of you may be using. Mandibular advancement device, which is an oral appliance that a dentist can make, where it's custom fabricated, where it gets you to sleep with a lower jaw extended forward, trying to help open and minimize tongue collapse. And then the newest one, which I'm sure most of you have seen the ads on TV with the remote control that people are putting against the chest, is called Inspire, which is a hypoglossal nerve stimulation. And that's indicated for individuals at moderate to severe obstructive sleep apnea that can't tolerate CPAP therapy. But it's an invasive implant that in essence stimulates a branch of the nerve that controls the tongue, which every time you inhale when you're sleeping, it causes that nerve to be stimulated, which causes two muscles below the surface of the tongue to contract, and it pulls the base of the tongue forward and the soft palate forward.
And how effective is this Inspire device?
It's quite effective. I mean, it's
Like what are the percentage?
the literature shows
improvement.
70 to 75% success rate. In my clinic, I specialize in these newer advanced therapies for sleep apnea, but I would say my patient population, I would say probably close to about 80 to 90% success.
But they must have failed CPAP, right? Or intolerant of CPAP.
Exactly.
Okay. And then what about central sleep apnea? Is that more common in Parkinson's patients? Because many of my Parkinson's patients have lost weight. They lose weight because of their poor sense of smell and taste, in which case obesity is not much of an issue, unless they're just, bedridden or just doing no exercise. But is central sleep apnea more common in Parkinson's?
Not that we're aware of.
Okay.
Yeah, not that we're aware of.
And the central sleep apnea, is that treated differently from CPAP effective for that, or something else is effective for that?
Yeah. So first off, what is central sleep apnea? So central sleep apnea is a different form of sleep apnea where you still stop breathing when you're sleeping, but it's not because of an obstruction. So it's got nothing to do with snoring or the back of your throat collapsing, the tongue collapsing. It's where basically the brainstem periodically stops sending signals to trigger the diaphragm to contract. Because when we're sleeping, the main muscle that triggers us to breathe at night are going to be the right and left diaphragm. So from a treatment standpoint, CPAP itself cannot take care of central sleep apnea because CPAP is just positive air pressure that's basically lifting and holding the throat open. In central sleep apnea, your throat is open already, so giving you positive air pressure is going to do nothing. There's a different kind of machine called adaptive servoventilation, where basically it's kind of like a ventilator. It still looks like a CPAP machine for all intents and purposes, but the device itself will actually trigger breaths to be given if it detects that you're not making an effort to breathe. There's also an implant for central sleep apnea as well that was FDA approved about 5-6 years ago called Remedy. Basically, it's like a pacemaker for the phrenic nerve. The phrenic nerve is the nerve that stimulates the right and left diaphragm. There's one phrenic nerve on each side. And this device actually is implanted kind of similar to the Inspire device, but in essence, it's constantly stimulating the phrenic nerve while you're sleeping to make sure the diaphragm always contracts and you're always taking a breath. So even if the brainstem decides not to send a signal for you to breathe, doesn't matter. This device is constantly stimulating the diaphragm to contract.
Okay, let's move on.
So there's a question in the back.
We have a question back here.
Brief one.
The new drugs from Lilly and Novo, which they're also using for sleep apnea, can that help in general sleep?
Can it help with?
General sleep? It's evidently working well with sleep apnea. And I forget the name, GLP-1s or something.
Yeah, so Zepbound is the GLP-1 GIP combination drug that was FDA approved on December 20th for use in obesity with obstructive sleep apnea. So it's only specific to obstructive sleep apnea, not for sleep in general, right? And the reason for it is that there's a higher incidence of obstructive sleep apnea in individuals that have obesity by using this specific medication. So the only one that's FDA approved for this specifically is going to be Zepbound, which is Lilly. But it results in weight loss. And we know that with weight loss, that can help potentially reduce the severity of underlying sleep apnea. So it's only specific to that. It's not, there's no data showing that it's going to help sleep in general. So
So any weight loss regimen can actually improve sleep apnea,
it can.
including
Yeah.
Ozempic and
But there's a misconception that weight loss will definitely resolve sleep apnea, right? Even bariatric surgery, the literature in bariatric surgery and sleep apnea has not shown that individuals that end up losing 60, 70, 100 pounds with bariatric surgery will always have resolution of sleep apnea. And the best way I have people think about it is when we all gain weight, which region of the body do we hold most of our weight, right? Is it our neck or down below in our chest and abdomen area? So if a person loses 60 pounds, they didn't lose 60 pounds here, right? I mean, they lost some weight in the neck and in the throat, but the biggest risk factor for any of us having sleep apnea is going to be inherently your anatomy. So,
okay, let's go on.
so now let's jump into restless leg syndrome. So approximately 15% of individuals with Parkinson's can have restless leg syndrome. What is restless leg syndrome? First off, so restless leg syndrome is a condition when you're laying in bed at night while you're awake, you can start experiencing a sensation of discomfort in the legs. It could be an itchiness, a creepy crawly sensation, but then it can be associated with an urge to have to move. And when you do move, those symptoms, that sensation that you're experiencing can actually be eliminated. If you stop moving, that sensation can come back. Now, some individuals will feel it, they'll move, and they're able to go to sleep. My wife has RLS really badly. Her mother has it as well, and it does run in families. But in her situation, when it's really active, she'll get in and out of bed for hours stretching because that discomfort, which is probably the most common symptom, usually a kind of an achiness. And most people, and I'm sure in your clinic you hear this all the time, but most patients, when we ask them, do you experience this? Most individuals will say, which is a dead giveaway that they definitely have RLS, is they'll preface what they're about to describe as, it's so hard to describe, but it's just this weird, deep achiness sensation. And when you hear a patient say that, you know they definitely have restless leg syndrome. But chasing after that sensation and constantly moving can cause a person to have a hard time falling asleep, right? It can also trigger difficulty with getting back to sleep, because some individuals will actually experience the symptoms again, can experience the symptoms again when they wake up in the middle of the night. So the prevalence of restless leg syndrome actually increases during the course of Parkinson's and even the treatment duration as well. Because unfortunately, dopamine agonist, which is a treatment for restless leg syndrome, has a paradoxical effect to where it can aggravate RLS or even potentially trigger RLS to occur. How often do you see that in your patients?
Quite a lot for patients on short-acting dopamine agonists with chronic use. Yeah. The long-acting dopamine agonist is much less common.
Now, individuals with RLS do have an older age at Parkinson's disease onset. They do have worse sleep quality and more cardiovascular anxiety disturbances. We also always check iron and vitamin D, specifically ferritin. Ferritin is a long-term marker of iron storage, and we've known this in our literature for quite a long time that low ferritin can actually impair dopamine production. So we always check ferritin levels, and a ferritin less than 75 nanogram per ml can actually increase the risk of developing restless leg syndrome. Vitamin D is more recent in terms of being identified to also play a role in dopamine production as well. So we also now check vitamin D. If the vitamin D is less than 50 to 75 nanogram per ml, it may also play a role in triggering RLS. I have many patients where, especially women and menstruating women, obviously losing iron regularly, just placing them on iron supplements and vitamin D, if indicated, can actually improve their ferritin level, can actually resolve the RLS symptoms pretty significantly. Also, withdrawal from dopaminergic agonists, antihistamines, and even antidepressants can actually trigger RLS as well. And even being on antidepressants can actually trigger RLS to develop as well. So,
And antihistamines.
antihistamines,
Yeah.
especially like Benadryl.
Exactly.
Now, periodic limb movements. So periodic limb movements is a very unique movement that only occurs when a person is asleep. It's usually a flexion type movement where it could be the toes moving, the foot tapping, or even just a leg just lightly twitching. One of the ways that we also will ask, individuals if they've noticed this or have this, most people don't know that they're doing it, and most spouses or bed partners don't realize it either, but we'll ask, have you ever noted that you've rubbed holes into your bed sheets where your feet lie? And when the individual's eyes light up because nobody's ever asked them that asinine question before, we know that they're having this repetitive stereotypical movement that over time, it's just wearing out the bed sheets, and they probably don't get pedicures regularly. Um, most individuals, but the problem with this condition is that we don't know why, but this movement can trigger the brain to wake up, and we still don't know why it actually can trigger an arousal. So an individual with, say, difficulty staying asleep may not have sleep apnea, but they may just keep having these repetitive movements when they're sleeping that keeps waking them up. And that's what we call periodic limb movement disorder.
And is there a cutoff number of the number of these limb movements per hour that you would say, yep, we got to treat this?
Yeah, so by definition, periodic limb movement disorder, it's called a disorder if during a sleep study during the night, because with home testing you can't detect this, but if a person has at least 15 movements per hour and at least 5 arousals per hour, and the person has daytime symptoms or nighttime symptoms that could be attributed, then you call it a disorder and you treat. There's many individuals that I've seen that have, sleep apnea, they're on CPAP, their legs are twitching at a rate of 50 times an hour, the brain is waking up 25 times an hour, but their quality of sleep actually isn't too bad, and they're sleeping great. So in that situation, we just document that, all right, you're having these movements, but we're not going to treat because it really doesn't seem to be affecting you, right? So why put a person on medication if it's not truly needed?
Agree. And then this is often, PLMS are often confused with RLS, right? And oftentimes patients come to me with a diagnosis of restless legs when in fact they have this PLMS. So can you just help us differentiate one from the other?
Yeah.
Even doctors make this mistake.
Oh, 100%. I mean, and even sleep physicians back in the day would diagnose RLS instead of PLMS. So
Right.
RLS is both are sleep disorders, but RLS is an awake disorder, meaning that RLS only occurs when you're awake and you know that you're experiencing those symptoms of RLS.
Meaning this urge to move, right?
Yeah, that achiness, that urge to have to move. When you do move, the achiness or that itchiness sensation stops. And then when you lay back down again and stop moving, it can come back again. So you start chasing after eliminating those symptoms. And that's how it can cause a person to have a hard time falling asleep or getting back to sleep.
And this is mostly nocturnal when they go to bed.
Most often, yes. And keep in mind, restless leg syndrome, it's a misnomer, right? Legs. Most individuals, yes, will have the symptoms in their legs, but it can actually occur in any skeletal muscle group. My wife also experiences in her neck. When she was pregnant, she actually had it in her arm. So during pregnancy, you can't take any of the medications except for third trimester. We were able to have her on clonazepam, but I ended up having to get her compression sleeves for her arms when she was pregnant to be able to help with the RLS symptoms in her arms. I've had patients that had RLS symptoms in the abdominal wall muscles. So the new terminology is called Willis-Ekbom syndrome. So there's 2 physicians that first described the disorder because the legs part of it makes it, a misnomer in the sense that it doesn't always have to occur in the legs.
Yeah, so some use the terms restless limb or restless body syndrome. And sometimes it gets a little bit confusing because you can have it in one limb.
Yeah, you can.
Yeah, so it really gets very confusing.
It does.
But are they treated similarly though?
Yeah. Yep, they are.
So what kind of treatments do you recommend for this?
For RLS and PLMS, it's thought that they both work on the same problem in terms of a dopamine issue. So the same medications that we use for restless leg syndrome, such as pramipexole, carbidopa-levodopa, even ropinirole can be used to treat both disorders. Preferably the longer acting is better. It's less likely to aggravate RLS. I've had patients that only had the periodic limb movements during sleep, and they were placed on short-acting dopamine agonists. Now that triggered them to develop restless leg syndrome. Gabapentin is our first line. So in our literature, the experts in restless leg syndrome and PLMS from Mayo Clinic and around the world have shifted to where they thought that the dopamine agonist drugs were the best thing for this condition. Now there's a lot of potential side effects, especially with the short acting. So it shifted in our literature in the sleep world to start utilizing gabapentin more often as first line treatment. We can also use in severe refractory. So there's many patients that have tried all these medications. We can even try a benzodiazepine. I have a few patients that we've actually had to use opioids. So opioids can be used, such as codeine, even methadone, very low dose methadone for the severe cases that don't respond to the traditional medications. We can use that as well. It's not very common.
And the good news is that the Parkinson's medicines actually work.
Yeah.
Yeah.
But the other thing too, though, is like, so there's literature showing that up to 70% of people with restless leg syndrome can also have sleep apnea. And treating the sleep apnea, improving the quality of sleep by virtue of treating sleep apnea actually can improve RLS symptoms to the point where they become very controlled to the point where they're not worthy of being treated. Maybe once every 2 weeks, they may experience symptoms. In that situation, we don't really put a person on medication.
Okay, we're running out of time. Let's jump to RBD,
Okay.
REM behavior disorder.
So REM sleep behavior disorder. So RBD is characterized by REM sleep without muscle atonia, which means that when we go into REM sleep, we're supposed to have full skeletal muscle paralysis. So we're supposed to be fully paralyzed when we dream. So RBD, what ends up happening is that you end up acting out your dreams. So you get motor and behavioral activity while you're dreaming. Usually occurs more in men than women. Usually emerges around 50 years of age or longer. Now, it's considered to be a prodromal condition of Parkinson's, meaning a precursor to Parkinson's disease. Now, the dreams in RBD can be very violent or unpleasant. Usually they're very action-filled, meaning that the individual is, being chased, or they're chasing after someone, or they're fighting individuals, or it can be, a lot of verbal altercations. Individual usually wakes up abruptly and they're completely coherent, so they're not groggy or drowsy. And that's one of the differentiating features of, sleep talking or walking when it happens in stage 3 sleep versus acting out dreams in REM. And then the dream enactment closely correlates to the observed sleep behaviors by the bed partner. So the bed partner history is very, very important when we're trying to determine if this person is having REM sleep behavior disorder symptoms. Now, common behaviors in RBD, the most common are going to be violent, punching, kicking, thrashing, leaping out of bed. Less common can be talking, such as giving speeches, swearing, cursing during the night. I've had patients do that, smiling or laughing, singing or whistling, shouting, swearing, like I mentioned, crying, chewing, grabbing, arm flailing, sitting up, crawling or running. Rarely smoking a fictive cigarette. Masturbation-like behaviors, pelvic thrusting, or even mimicking eating, drinking, urinating, and even defecating. Those are rare. I've not seen any of those. It's also important to note that the eyes are closed during this behavior because the person truly is asleep when this is happening. They truly are literally acting out exactly what they're dreaming at that moment in time. So if you're witnessing it, you're actually witnessing exactly what they're doing in their dream at that specific moment. Now, the diagnosis is a combination of having a clinical history of this behavior, but then there's specific features that we have to look for during a sleep study. So that we actually add extra sensors below the chin and on the arms, and we have to look to see when a person enters into REM sleep, which we look at that by looking at the brain activity when a person sleeps. Are they fully paralyzing themselves or not? That's a key feature. And we look for that all the time, even in normal individuals that don't have this history. We're always looking at that. And we don't have to necessarily capture dream enactment behavior during the sleep study on the video. So it's not often that we'll capture it, but we just have to look to see if a person is paralyzing themselves or not. So if they have that plus a clinical history, then we diagnose REM sleep behavior disorder, and then I send the patient to Dr. Evidente for further workup, and I'll explain to you why. Now, the course is usually gradual, but occasionally rapid onset, with the course being very progressive. So the typical history is going to be, male in their mid-50s coming in, reporting that, my wife has been reporting that for the course of the last, 6 months, every couple of times a month, I've been, punching, thrashing. I punched her in the back before, and she woke me up, and I didn't realize I did it, but I remember that I was, someone was attacking me, and I was kind of protecting myself. And then over time, it goes from maybe once every 6 months to once a quarter to once a month to once every 2 weeks to now it's occurring every night. So it's a very slow progression, right? That's kind of the typical history that we'll get from individuals with this disorder. Now, the prevalence of RBD and Parkinsonism is quite high, right? So on the table on the right, we're looking at Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy, which are going to be the three main alpha-synucleinopathies that Dr. Evidente, of course, manages being a neuromuscular disease specialist. Multiple system atrophy, which is likely the rare of the three, up to over 90% of individuals will have this REM sleep behavior disorder. Close to 90% of individuals with dementia with Lewy bodies will have RBD, and over 75% of individuals with Parkinson's will have REM sleep behavior disorder. Now, the typical timing of RBD, again, occurs when we dream, right? That's why it's called REM sleep behavior disorder. Now, this image on the right, that is what we call a hypnogram. So that basically shows what our quality of sleep is like. So this is a normal individual, a normal picture. It's like, can you see my arrow? Oh, good. So this is at the start of the night. So that's when a person is asleep. The brain then goes into stage 1 sleep, progresses into stage 2 sleep, and the sleep cycle in the start of the night will go into stage 3 sleep, and then it finishes with this red, which is REM sleep. And then every 120 minutes or so, the brain completes a new sleep cycle. Every sleep cycle terminates with an episode of REM sleep, and you can see that as the night progresses, the red bar is getting longer, right? And that's reflective of as the night progresses, we spend more and more time in REM, with the longest time in REM typically within the last 2 hours of when we wake up. Most individuals with RBD typically will exhibit this behavior generally in the early morning hours, typically 2 o'clock in the morning or later. And that's one of the things that we'll ask spouses, what time of the night is it that you're experiencing it? Is it in the first half or the second half? 99% of the time, second half of the night, right? And that's because that's when we spend the most amount of time in REM sleep. Do we have time for this?
No. Let's proceed to the next one.
Sorry, it was a good video. So what are the clinical implications of RBD? So RBD is strongly associated with alpha-synucleinopathy degeneration, that's what these conditions, Parkinsonism, are categorized by. So it's important to note that an autopsy series found that underlying synucleinopathy was present in 94% of individuals with RBD. Alpha-synuclein is a protein that is overproduced and that's involved in the development of Parkinson's and these other disorders, but found in individuals with RBD even before he or she develops symptoms of Parkinson's disease. And Dr. Abdineh can even touch more on that because I refer all patients that we diagnose with RBD, even if they don't have symptoms of Parkinson's, I'll refer them to him because there's a workup that he does, including a skin biopsy and a brain scan that can help to let us know if this individual has, potentially early Parkinsonism. Now, what is the progression risk, right? Why is RBD so important? Because RBD can actually develop 30 years before an individual actually develops Parkinson's disease. So there's many, many patients where I've diagnosed with RBD and I've had to be the one to tell them, even before I send the patient to Dr. Evidente, is that you've got RBD, there's a high risk that within the next 30 years that you're going to have Parkinson's disease or one of these other disorders. So the progression risk is over the course of 2 to 5 years after being diagnosed with RBD, there's a 15 to 35% risk that he or she will develop Parkinson's. Over the course of 12 to 25 years, that risk of progressing to Parkinson's is about 41 to 91%. The better way to think about it is that individuals diagnosed with Parkinson's disease today, there's a 25% chance that he or she will develop Parkinson's in the next 5 years. There's a 50% chance that he or she will develop Parkinson's in the next 10 years. There's a 75% chance that he or she will develop Parkinson's in the next 25 years, and a 90% chance that he or she will develop Parkinson's in 30 years. So it is a very, very, very important condition that's often misdiagnosed or not recognized, even by sleep specialists, which is unfortunate, but it's a very, very important condition.
Okay, so I guess RBD could be used as a non-motor symptom to screen for Parkinson's, right? Together with loss of sense of smell. So for patients of ours that their family members can ask, okay, am I at risk for developing Parkinson's? Or I'm a vet and am I at risk for developing Parkinson's? Or there's a question here, I work for the US government, what should we do to screen government federal employees for Parkinson's? I guess screening for RBD and loss of sense of smell would more or less be the two biggest non-motor symptoms that can help us predict whether one will develop Parkinson's or not. And Dr. Patel just gave us the numbers or the statistics. But is RBD a bad thing, and should we treat it?
Absolutely. It can be very dangerous.
Uh-huh.
I mean, I remember when I was a fellow in Chicago, I had a older couple come in a clinic, and the spouse was quite frail, but had a black eye, and it was
Wow.
because the husband, who had Parkinson's, was undiagnosed with RBD, but in the middle of the night when he was dreaming, he was fighting people, and he was unfortunately punching his wife
Oh my God.
unknowingly and gave her a black eye. It can be very dangerous.
Yeah, I had one patient where the spouse, who happens to be a vet, pulled out his gun
Mhm.
and pointed at his wife, and unfortunately it wasn't loaded. But it's not. Yeah, and at that moment I said, "Wow, we got to treat this, no doubt." And first things first, take out all the guns from the house.
Yeah, I mean, from a treatment standpoint, like this says here, I mean, there's a lot of behavioral strategies. We see, the gentleman here mentioned being told putting a mattress on the ground. That's to soften any falls. But we recommend putting a pillow between the nightstand and the edge of the bed. So one of our colleagues, Dr. Nita Lauren, had a patient with RBD who was so active that rolled over and got the head stuck in between the mattress and the nightstand and was still acting out, and unfortunately, broke their neck. That's extremely rare. But ever since she told me that story years ago, I always make sure that always put a pillow in between the nightstand or move the nightstand away, from the bed.
And is this the same thing as sleepwalking?
No, totally different. Sleepwalking occurs in the first half of the night, and it occurs out of a different level of sleep, stage 3 sleep. Whereas RBD occurs typically in the second half of the night out of REM sleep. And it's very characteristic. I mean, you can look at an individual and know exactly what they're doing.
What about night terrors? Is it the same as night terrors?
Completely different. Night terrors also is something that occurs in the first half of the night out of stage 3 sleep. Usually the individual looks frightened, but you cannot get them out of it. And that's night terrors. In RBD, you can wake the person up. And like I said, they're completely coherent. They just don't realize that they were acting out their dreams. But if you ask them in that moment in time, what were you dreaming about? They'll be able to tell you.
Okay. Time for one or two questions before we wrap up. Yes, go ahead.
Okay, I'm trying to figure out where my crazy self fits into this, but I suspect one of my Parkinson's medication, maybe pramipexole, gives me OCD, and it makes me, I'm driven all the time, and I'm in the middle of the night, I'm rearranging furniture, moving pictures on the wall.
You should come to my house.
Yeah. Well, when I walk into your office, I want to move pictures.
I know the patients with OCD, when they come to my office, got lots of paintings. They gotta say, "Oh, that painting's twisted. I'm gonna arrange it for you." They kind of. Go
But
ahead.
I don't know, I feel like this is disturbing my sleep. Do you know?
Yes.
I feel driven and yeah, I don't sleep.
So I'm glad that you brought that up, because that's something that we always have to be aware of. So these medications that are used to treat Parkinson's are dopamine agonists, right? And dopamine is the pleasure neurotransmitter in the brain. And a side effect of these drugs is it can trigger compulsive behaviors, which is exactly what you're describing, right? And the compulsive behaviors could be having to rearrange furniture. It could be excessive drinking. Shopping is a very common one. Even excessive. I've had patients in the past that I've met that were committing adultery, and it could be gambling. I've had women that have gone to Salt River Casino and spent $40,000-$50,000, and they just couldn't understand why they were gambling so much. And that's a side effect of these medications, and it can occur with any dose of the medication, right? So, but yeah.
So you gotta. What he's trying to say is that you gotta get off the pramipexole if you want this to resolve. We have to find alternatives for that. Although the pramipexole is good for tremors, your Parkinson's, your restless legs, maybe your periodic limb movement. It's not good for OCD. And if you have OCD, it has to go. Agree, but we'll ask your doctor to find alternatives that will not cause the OCD. Okay, next.
I noticed you skipped over the slide on excessive daytime drowsiness. Could you just go back to that and spend a minute on it?
Okay, go ahead.
So about 21% of individuals with Parkinson's can have excessive daytime sleepiness. So there's multiple reasons why a person with Parkinson's can have excessive daytime sleepiness. One, it can be just because of the Parkinson's itself, right? Dopamine also is one of the main wake neurotransmitters, right? So dopamine wakes the brain up. So just the degenerative process that causes Parkinson's to develop and the reduction in dopamine production can actually trigger daytime sleepiness. Two, the medications, right? A side effect of the dopamine agonist medications that's used to treat the symptoms of Parkinson's can cause daytime sleepiness, even sudden sleep attacks, like I mentioned earlier. Three, having poor sleep, whether it's insomnia, whether it's untreated sleep apnea, whether it's restless leg syndrome, the periodic limb movements during sleep, all of these things can impact quality of sleep or cause sleep deprivation, and that can cause daytime sleepiness. So while it's common to have daytime sleepiness in the setting of Parkinson's, it's not a healthy thing, or it's not a good thing, and it's not a normal thing because there could be a cause for it, right? There definitely could be a cause for it. And many of my Parkinson's patients that have daytime sleepiness, majority of them have a sleep disorder. Once we correct it, the daytime sleepiness can improve dramatically. It may not completely go away because remember, Parkinson's itself, the pathology of Parkinson's and the pathophysiology of Parkinson's can cause daytime sleepiness because of the reduction in dopamine. But when you remove the other sleep issues to optimize sleep, that can actually definitely improve. And then, of course, when a person is better rested and less tired, that improves quality of life and mood, right? And that can also help to improve this, symptoms of Parkinson's during the day as well.
So is coffee or caffeine a good thing for sleepy Parkinson's patients?
In moderation, yeah, sure.
Moderation means how many cups?
I guess that's a very definition, right? I would say maybe no more than 8 to 16 ounces, but before 3 p.m. caffeine before 3 p.m. So it doesn't impact quality of sleep because it takes us about 6 hours to metabolize the last bit of caffeine that we consume. So that's why we always recommend no caffeine after 3 p.m. if possible.
And then do you use these stimulants like Ritalin, modafinil?
We can. Yeah, there's wake promote.
Yeah.
There's medications that we can use that can help to increase, the neurotransmitters that wake us up. So there's medications that could be used first thing in the morning. You can take in that can help.
And then if you're sleepy during the day and the stimulants don't work, you recommend maybe a half an hour nap is okay, not more than that?
Yeah, half an
And
hour
before
nap
3 p.m.?
Before 3 p.m. Yeah.
Okay, we got to wrap up. One more minute.
I'm sorry, I'm obviously have a lot of sleep issues, and I'd love to take you out to lunch, or dinner, or maybe buffet. Couple things. One, the date that I had my first experience of RBD was exactly 15 years before my diagnosis of Parkinson's disease, and it was at that time that they diagnosed me with RBD as well. But I remember the first night, it was a violent thing. I was helping the police. I put my thumb in my eye. That woke me up. In the morning when I woke up, I had just no white, no sclera. It was all magenta. So subsequently, I diagnosed 15 years later with PD. My question is about diagnosing RBD in terms of the sleep study. I've had the opportunity to participate in a study done here locally on folks with trying to, by stimulating the vagus nerve, maybe making sleep more beneficial or more getting to sleep and staying asleep better. So I've had a full-blown sleep study where I had things stuck on parts of my body I couldn't find later on. And then during the study, they just used, they gave me a treatment with this stimulator. It was just kind of an electric stimulation. And then they put a little thing on your thumb and hooked it up to your cell phone, and I did it overnight. So the difference between just a night on the thumb and the night with all these things, is one more proficient, one more diagnostic, or are they equal? Because I've had a number of folks, I've seen a number of folks where they have had these testings done through a sleep center and not a certified sleep study. What is the difference, and which one should you have to make this diagnosis?
I mean, I'm not sure what the study, the other one that you did where you were, it sounds like you had vagal nerve stimulation and something. I'm not,
It's probably the vagal nerve, yeah.
yeah. Yeah. So that's all clinical research based. So I'm not even really aware what that exactly is. So that is not standard of care. Standard of care for RBD based on our guidelines is exactly what I described with going into the sleep lab and doing the sleep study. So, yeah.
We have one more question.
Okay, one last question, please.
One last question. Teeth grinding, keeping somebody awake,
Roxanne.
and mouth guards don't work. What about this high-glossal nerve stimulation? Others have told me that you can have Botox injections to keep your mouth from grinding. Is there any help for that?
You wanna, okay,
Yeah.
you first, then I'll.
Yeah. So teeth grinding actually is a very common symptom of untreated sleep apnea, first off. So very, very common. So dentists will send us patients for individuals with very severe bruxism, it's called, or teeth grinding to the point where they've developed severe TMJ issues, and they'll send them, say, please rule out sleep apnea. Even in children. So sleep apnea, untreated sleep apnea in children can cause teeth grinding. Even in adults, it can cause grinding. It's thought to be the result, kind of a stress response to the physiologic stress that sleep apnea triggers. Answer your question about the hypoglossal nerve stimulation, the Inspire. Keep in mind, again, it's only going to be indicated specifically for moderate to severe obstructive sleep apnea if you could not tolerate CPAP. It's not indicated for teeth grinding specifically. So in this situation, if a person has severe teeth grinding and they also have untreated sleep apnea, treat the sleep apnea. That should help to improve the teeth grinding.
And then the Botox, yes, it works. Botox works, but it causes difficulty chewing after the shots for a few weeks in some patients, and difficulty swallowing and dryness of mouth. Yeah.
So you won't grind, but then you'll drool.
Exactly. Here's what you want to do at night, I guess, huh? Grind or drool.
Awesome. Well, thank you, Dr. Patel and Dr. Evadante, for sharing your experience and expertise. Yes. I'd like to acknowledge and thank our exhibitors for their role in the program: Abbott, Acadia, Abbey, Amneal, C&D, Medtronic, and Supernus. We will now draw our raffles. So get those raffle tickets out.